It's another iteration of Vivek's takes, despite the fact he is on trains, buses, taxis, planes, everywhere around the globe. Finally, I was able to pin him down for the next 30 minutes where he is unable to move, unable to go anywhere, and he's going to tell us his takes on ESMO 2024. Welcome, Vivek Subbiah, back to the Healthcare Unfiltered show.
Thank you so much, Shadi, for having me. Thank you so much. It's a pleasure and honor to be again on this platform.
Well, it's
After
Vivek's
ASCO
takes.
takes,
It's after each meeting, like you've committed to this, you know.
yes, yes.
The good news is that we don't pay Vivek to be on Healthcare Unfiltered. Thank goodness.
Thank you. So
So,
again, ESMO was a phenomenal meeting.
well, we're going to talk about your takes on ESMO because this is the topic of the show. But before that, this show is airing in November 2025, 2024, 2025. Look at me.
Yeah.
I'm losing my mind. But you recently, before we go into ESMO, you recently had a debate, some AACR debate where you are arguing with somebody about something, and you're always arguing with these people. So tell us about the debate and what was the topic that you were debating.
So again, I would call it the debate of the year, right? I think it was very interesting because it was an AACR 2024 AACR roundtable. And again, Dr. Lillian Su is the new incoming president-elect for AACR. And, I think her vision was that she wanted to have something unique because, instead of didactic lectures on AI, she wanted to have some debates and some insightful commentary.
I should have been the
So,
person referring this debate. You're talking AI, and I'm not referring. Okay, keep going.
yeah, so the session was essentially integration of early cancer detection and AI-driven technologies will become standard practice in oncology and increase cancer cure rates by 2024. So that was the topic. And in fact, it was moderated by Dr. Alicia Sequist from
Mass
Harvard Medical
General.
School.
Mass
Yeah,
General,
Mass
yeah.
General Harvard Medical School. Right. And then my pitch was, as everyone knows, and you know, that I am a major believer of AI. AI, is going
Smart
to
man. I
take over.
like it.
AI is going to take over this, right? AI, someone said it's going to take 1,200 to 1,600 years to cure cancer by the rate in which we are doing cancer research. So the only way something can happen to the system is something like AI. So I spoke from the enthusiast point of view, and Dr. Alex Pearson
I know him very
from
well, University of Chicago.
University of Chicago, from the AI Center, Computational Medicine, and he was being the realist, saying that AI cannot do that. AI is not ready to do that. AI will not do that.
Who won
So
the
again,
debate?
of course, of course, of
It's a
course,
silly
I won the
question. How
debate.
dare I ask?
Unprecedented. I
I
won the
mean,
debate by far. Like probably
did
98 is to 1, 98 is to
yeah,
2,
I kind of
right?
feel
Believe me,
bad for
everyone was
Alex now.
talking about it.
So before we get into ESMO, what were the top four selling points that you presented that won you the debate? Because I wonder if I ask Alex right now, he's going to say that he won the debate.
Believe me, everyone's talking about it.
So tell me
Everyone's talking
what
about
were
it.
your major four selling points?
Again, main thing is that, right, oncology, when we think about it, it's a pattern recognition specialty. Right? Think about that. Again, uh, think about the diagnosis. Right from diagnosis, what we make. Pathology is a pattern recognition. And when we look into radiology images, it's all pattern recognition. And endoscopic videos, it's all pattern recognition. So all these three can be readily, complemented and supplemented with AI.
Hmm.
And again, think about that, right? Again, three different areas in oncology, right, are all pattern recognition, and AI can easily take over that. Again, it's not going to, my point was AI is not going to replace humans, but humans with the assistance of AI are going to be replaced, humans without AI will be replaced by humans with AI. That was
Very
my point.
interesting.
Yeah.
I tend to agree with you, obviously. I was just curious to see what was the opposing side of Alex. What did he try to counter? Poor guy.
So again, his point was, as a realist, I think was well taken, right? I think he, as a realist, essentially he felt that we are not ready yet, right? The AI algorithms are not ready yet to make those diagnoses, right? Again, all his concerns are valid, right? It is important to recognize the tremendous strides that we made in improving AI technologies, right? Again, he was worried about the diverse data sets that are not ready for prime time, that are used to train and have bias, and we need to improve the fairness in the training data sets. And I completely agree with some of those, right? Of course, the 2024 AI is not the same as 2023 AI. There is
Yeah, for
continuous
sure.
research and development in addressing all these limitations, right?
For sure.
And
For
AI
sure.
is designed to complement, not replace human expertise. So the last, what we came up with was, will AI replace humans? I
No,
say
no,
no, right?
no.
Humans without AI will be replaced by humans with AI.
You're absolutely correct, and I'm on your side, and I understand why you won. Smart man, speaking from personally being chief medical officer of an AI company.
Again,
So,
AI is going to allow healthcare professionals to focus on
absolutely,
complex
absolutely. I think
decision-based making tasks, right?
people
Yeah.
who are not going to really get into the AI, they're going to really be left behind. So let's move on to ESMO 2024 Vivek Stakes. As you know, after each major meeting, we bring you on the show so you can share large observations. We do not need to go deep into the data. We understand there's going to be a lot of nuances and details, but we're always curious about your thoughts, large observations, impact on trials, impact on practice. So broad strokes and big picture. Let's start.
Absolutely. I think, ESMO was fantastic. So let's talk about three different things, right? So we had concurrent NEJM publications. Those are some of the big picture. We'll talk about two or three of those now, and then we'll talk about two of the special sessions, and also importantly about some of the precision medicine studies that were presented there. So regarding the New England Journal of Medicine concurrent publications, right? Again, our kid on the block, our old kid on the block, cabozantinib, the phase 3 trial with neuroendocrine tumors was done, right? They did, as you know, advanced treatment options for neuroendocrine tumors are limited. And here they tested cabozantinib in extrapancreatic neuroendocrine tumors. And interestingly, compared with placebo, the cabozantinib multikinase inhibitor significantly improved PFS in patients with progressive advanced extrapancreatic tumors. Again, that was a phase 3 study published in the New England Journal of Medicine, and that was presented at ESMO. I think that was a practice-changing study. And I think again, we have cabozantinib, we use it for thyroid cancer, right? Kidney
And for
cancer.
kidney cancer.
And then it's also used in hepatocellular cancer, right? And now it's interesting that this drug is still multi-kinase drug is working in advanced neuroendocrine tumors. The second one is Claudin antibody. Again, that was also a concurrent New England Journal publication. Zolbetuximab in gastric or gastroesophageal junction adenocarcinoma. So the addition of zolbetuximab, an anti-Claudin 18.2 antibody to chemotherapy, led to prolonged progression-free and overall survival than chemotherapy alone. And interestingly, there was another study in gastric cancer space, again, preoperative chemoradiotherapy, and that also showed the addition of preoperative chemoradiotherapy to perioperative chemotherapy did not improve overall survival compared to perioperative chemotherapy among patients with resectable gastric cancer. And again, these are all drugs, right? Drugs and clinical trials. One of the interesting publications that came concurrently with ESMO was a cachexia drug, right? Cachexia, right, is a common complication of cancer associated with increased risk of death. And interestingly, there has been an observation that the level of something what we call a GDF15, growth differentiated factor 15, circulating cytokine, is elevated in cancer cachexia. And this was a phase 1 and phase 1b study involving patients with cancer cachexia. And there is this drug called ponsegromab. It's a monoclonal antibody inhibiting GDF15. And it was associated with improved weight, appetite, and physical activity, right, in the phase 1 study. So they did a phase 2, a randomized double-blind 12-week study. And interestingly, among patients with cancer cachexia and elevated GDF15 levels, the inhibition of GDF15 with this drug, ponsegromab, resulted in increased significant weight gain, an overall activity level, and reduced cachexia symptoms that confirmed the role of GDF15 as a driver of cachexia. So I think it'll be interesting to see how this drug will be used together with other anti-cancer therapy agents in cancer cachexia. I think this was
I like this.
yeah.
I really like studies that focus on supportive measures,
Yeah,
supportive care. These are important.
yeah.
I think they also add quality of life. I'm also very impressed that they were able to do a randomized phase 3 trial with this.
Yes, yes. In fact, again, this was a clinical observation. Again, this struck me because GDF15 is also in the same pathway as RET. And you know that I worked on RET inhibitor clinical trials before, and it was a clinical observation that we saw weight gain in patients on RET inhibitors, selective RET inhibitors. In fact, we published that showing that the RET GDNF pathway, target, could be the reason why these patients gain weight. And of course, we attributed that initially to, again, patients with non-small cell lung cancer or thyroid cancer patients with cancer having cachexia and then being them treated on an effective drug gaining weight. But beyond that, we saw excessive gain weight, patients gain weight on this, and we made a clinical observation, and we also published that, I think, a year ago in Annals of Oncology. And seeing that one of our basic science colleagues is looking into the RET GDF pathway to see if, selective RET inhibitors can be used for cancer cachexia. Again, he's working on preclinical data. And then when this one showed that GDF15,
very interesting.
It was very interesting.
Very interesting.
So interesting that ESMO, ESMO and New England Journal coordinated to put this as one of the important, practice changes in oncology on cancer cachexia.
Other themes, you mentioned one of the other themes that were intriguing to you were precision medicine or something like that.
Yeah, no, absolutely. So again, two important topics for precision medicine, two important sessions for precision medicine, right, in ESMO. One was important presidential symposium. They called it the Eyes to the Future.
Eyes to the Future.
Eyes to the Future. Again, Dr. Fabrice from Gustave Roussy, a great colleague and friend, led that session. He was a chair with Nadia. And it was like back-to-back proffered papers. Again, the first one was the Rome trial from histology, to target. An interesting study, precision medicine study from Italy. Again, it was like one of those drug rediscovery protocols. And they repurposed approved drugs to target patients with based on molecular tumor boards, and they showed good data. So that was one that was featured on the presidential symposium, and they had some late-breaking abstracts, right, moving towards molecular and coming back to us AI-driven oncology, right? So they spoke about systemic therapy for organ preservation, and they also had discovering mechanisms of resistance to standard therapy. And interestingly, they also had another talk on PRMT5 inhibitor on MTAP.
What's that? Which one is the?
The PRMT5 inhibitor which was the Amgen 193, the Amgen drug, AMG 193. It's an MTA cooperative PRMT5 inhibitor in patients with MTAP deleted tumors. Again, it was a phase 1 study. And we see MTAP. MTAP seems like a emerging tissue agnostic target that's seen across multiple solid tumors. And to do MTAP detection is based on IHC. Of course, you can do it by NGS testing as well, but MTAP detection is from IHC. And based on IHC testing, they showed that this could be potentially a tissue agnostic target with tissue agnostic drug potential across multiple tumor types. Again, this is an epigenetic drug, epigenetic target drug. So the invited discussant was, again, Sigal Kadoch from Dana-Farber. She did a fantastic job of talking about epigenetic modulation of the tumor and its microenvironment. And in fact, in the same session, they had a nice talk on molecular and AI-driven precision oncology. Because there was another talk in the same session titled Application of GigaPath, an open weight billion parameter AI foundation model based on novel vision transfer architecture for cancer mutation prediction and TME analysis. Again, that was an interesting.
So when they say AI-driven precision oncology, simplify this? What does that mean? Is it really finding the proper target for particular assets? Is it developing the proper asset for a specific target? Is it none of the above? What is precision oncology AI driven?
So again, what here they showed was mutation prediction.
Predicting mutation.
Predicting mutations, right? So broad picture, not this program, broad picture for the broad audience here. So there is always a critique about NGS that this is expensive, right? How can we predict a BRCA mutation? How can we predict MSI high? Do we need to do the comprehensive genomic panel that costs thousands of dollars? So by just an AI algorithm, by just looking at a slide, an AI algorithm can show us if that patient harbors a BRAF mutation, a BRCA mutation, or MSI high. So we can enrich that patient to be tested, right? Many LMICs cannot afford NGS, but of course they can. If the AI algorithm can be simply plugged in, it costs less than $2.
Yeah.
So even for resource constrained settings, AI algorithms can be used to detect all these targets for mutation prediction, right? And again, not relevant for this, but again, the one thing we brought up in that AACR meeting as well is, I think AI technology is going to be leapfrogged in LMICs.
I totally agree with you, actually. I think that no matter how cheaper genomic profiling becomes in the US, and frankly, it is going to get cheaper with time, right? I mean, even cheaper than current prices, it's going to still be expensive for low middle income countries. It's just not really easy. And being able to use AI for pathology, for other elements, is going to be key to predict which markers.
Many countries cannot, many states will not have radiologists in many countries, right? Mammography, pathologists. So I think AI can, again, they don't have legacy systems, many countries. So they can directly leapfrog to a future of AI technology, which is much cost effective and cheaper. On that vein, coming back to all the ESMO, right? ESMO.
Yeah, exactly. Well, we've gotten two themes. You told us about the AI, precision medicine, and the first theme as well.
Yes. So, again, they had a special session, ASCO, and ESMO had a special joint session. And in fact, Dr. Andres Cervantes, the president of ASCO, and Dr. Robin Zahn, the president of ASCO, co-chaired that session. So that session, they had, the first topic was promise of patient-derived organoids. And the second was, I gave a talk on tumor-agnostic biomarker-driven drug development, how and how often. And coming back to AI, again, ESMO started with AI talks. Dr. Furman from Netherlands talked about novel AI-enabled strategies in biomarker-informed clinical trials. And Dr. Julie Grallo had a fantastic talk, put the whole session together. She weaved our tumor agnostic AI and the organoid talks together on this talk titled Regulatory Sandboxes: How to Synchronize Safe, Timely Regulation with Scientific Breakthroughs in Molecular Niches. I think, again, I may be biased because I was in the session, but this was one of the best sessions
I'm
of
going to try
ESMO.
to find it. I'm going to try. I did not listen to it. I did not make ESMO Live this year, next year, but I'm going to definitely listen to it.
And, finally, right, they had several studies that were showcased to show the value of molecular profiling to inform precision oncology. They had presentations on the FinProof, which is a prospective open label basket and umbrella study of a DLCT. What's a DLCT? You may know what's a DLCT, DRUP-like clinical trials, like DRUP. DRUP is essentially, for our, broad listeners, it's a drug rediscovery protocol, right? We all know that approximately 20% of patients with advanced cancer who have an actionable mutation for which a targeted therapy is registered outside a corresponding indication may not have access to the therapy. See, for instance, a patient with colorectal cancer and a BRCA mutation may not have access to PARP inhibitor, right?
Right.
So the DRUP, right, the drug rediscovery protocol in the Netherlands, provides these patients access to targeted therapy and investigates the effectiveness of targeted anti-cancer drugs and immunotherapy drugs outside these labeled indications. So again, there were many DRUP-like clinical trials that were presented at ESMO. I think I should commend the ESMO group.
That is very interesting, actually. That is very interesting.
Sessions, essentially. The FinPro was there. They also had a talk about ESMO, the SCAT scale that was also published in Annals of Oncology. And again, they had the Primrose study, which is again a DRUP-like study. And the Primrose is a European Cancer Mission project on precision medicine trial across a broad variety of tumors. So the project involves 11 ongoing or planned DRUP-like clinical trials that are aligned in terms of their protocols and endpoints, right? So again, I like the DLCTs, I call them again, DRUP-like clinical trials that explore the effects of biomarker-driven treatments outside their indications across a broad variety of tumor types.
But Vivek, isn't that the TAPR approach from ASCO?
Yes, absolutely. In the US, it's ASCO TAPR, and of course the NCI match program, right?
Yeah.
So in Europe, they don't have ASCO TAPR. Or the
so
NCI
they're using
match.
that's what they call it, basically.
They
That's
call
really
it the DRUP-like program, right?
Yeah.
So for us, once a drug is FDA approved, it's okay, right? For them in Europe, they need to have EMA approval. Then they need to go through HTA assessment for each and every country. And then, it's a challenge. The patients don't have access to.
And then negotiating the prices, which sometimes may
Exactly.
not really to something.
Exactly. So this is an innovative approach by the EMA and, the European colleagues, that data from all these DRUP-like studies, the DLCTs, may be required for cost-benefit assessment of new therapies. And in the regulatory bodies are also, again, planning about more flexible and adaptive framework to assist in therapies based on real-world evidence, right? Genomic data. We always talk about real-world evidence, but I think the DLCTs have proven some real-world evidence based on genomic data. And of course, there are limitations, right, to all these DLCTs, right?
I also think TAPR is real-world evidence. And at the end of the day, it's like really, I mean, I think people, you have a marker, you're using off-label indication, and the company is providing the drug.
Yes.
Well, this was really a nice, quick tour around ESMO and the fact that you crushed the debate as well. So, I mean, we only bring winners here to the Healthcare Unfiltered. No, Alex is a winner. He's a winner. He's a great guy.
By far. I won the debate. I won the debate in an unprecedented way.
I like it. Well, Vivek, this was really nice. Did we miss anything about ESMO? I think your next appearance, when is your next meeting? Are you going to ASH or ASCO GI or ASCO GU?
ASCO GI and ASCO G, one of those. Yeah.
Yeah, well, I'll be at ASCO GU. I don't know if I'm going to make it to ASCO GI, but we'll actually bring you back to go over some of your observations. Of course, then the ASCO coming. I think ASCO is coming rapidly to Chicago. I can't believe how time is flying by, to be honest.
Yeah. In fact, the next meeting is going to be next week. It's going to be in the White House, and it's a cancer, moonshot initiative.
Yeah,
And it's
well,
going to be. I learn a lot from that and see how we can. Again, we do a lot here in the U.S. and across the side on the
yeah.
other side of Atlantic, but the rest of the world, 2/3 of the world, is not benefited from these precision medicine studies. So I think this is a think tank to think about how we can think about global harmonization.
Vivek Subbiah, Chief of the Early Phase Clinical Trials at Sarah Cannon Research Institute, a guy that is without, everybody knows who is the Vivek Subbiah. And Vivek, before I let you go, what is your favorite book, Vivek Subbiah? I mean, hint, hint, there are two books behind me. I mean, you can
So
choose.
there
And
are two books, right? I don't know if there is one book. There are two books. One is the toxic exposure, and the other one is the cancer journey.
there you go. That's
And
my boy. I
to
like it.
our listeners out there, we're going to do a podcast
Yes.
with some of your friendly neighborhood friendly colleagues, oncology
Yes,
colleagues,
please
on
do.
one of
Please
these
do.
books soon. Yeah, yeah.
Please do. Thank you so much, Vivek, for coming on Healthcare Unfiltered. I know how busy you are. Really appreciate your
Thank you.
time.
Thank you.